Modernizing rural healthcare networks across vast, isolated geographies requires immense physical capital, deep technical infrastructure, and exact administrative precision. Under the CMS Rural Health Transformation Program, New Mexico is allocated a massive budget of $200 million per budget period. That annual allocation compounds over 5 federal fiscal years. The state is preparing to deploy $1 billion in total. Rapidly injecting this volume of capital into a state system is dangerous. Without proper architecture, it creates severe administrative bottlenecks and risks violating federal compliance rules. To understand how New Mexico plans to survive this influx, we must map their program architecture directly against the strict funding constraints outlined by CMS. Successfully absorbing $1 billion requires precise structural engineering. The state must build a specialized architectural pipeline to manage this level of capital. We start with the target demographic. This map isolates New Mexico's HRSA-defined rural census tracts, many of which operate as severe health professional shortage areas. These specific tracts are the direct destinations for the state's intervention and infrastructure upgrades. Reaching them is complicated by the Federal Notice of Funding Opportunity, or ENFO, which dictates how the money can legally move. CMS enforces exact financial ceilings. There is a hard 15% maximum on direct provider payments and a strict 10% cap on administrative expenses for the primary recipient. If the state healthcare authority attempts to centralize the execution of this massive grant, they will immediately breach that 10% administrative cap. To survive the federal caps and still reach the rural targets, New Mexico has designed a decentralized capital distribution model. This stacked bar chart breaks down how New Mexico divides that $200 million annual budget across 5 distinct strategic initiatives. The largest single allocation goes to Healthy Horizons, which commands approximately $76 million in the first fiscal year alone. The operational goal of Healthy Horizons is expanding specialty care access. It funds direct provider e-consults and establishes in-person rotational clinics so patients avoid traveling to cities. The remaining budget is split between 4 other initiatives: Rooted in New Mexico for workforce training, the Rural Health Innovation Fund, Bridge to Resilience, and the Rural Health Data Hub. The clinical access and workforce initiatives maintain massive, sustained funding year over year. In contrast, the Data Hub requires a smaller, decreasing footprint as its physical infrastructure is completed. This specific weighting aligns directly with the CMS mandate, which requires states to prioritize immediate healthcare outcomes and community-designed solutions over endless planning. Allocating funds based on frontline clinical needs forces the capital outward, preventing the accumulation of bloated, centralized administrative silos at the state level. That outward push is vital when you remember the CMS NOFO constraint, the 10% administrative cap threatening the primary recipient. This financial flow network visualizes New Mexico's structural workaround. The state routes 95% of total direct charges outward, channeling the money into external contractual agreements and subawards. This mechanism directly insulates the core state healthcare authority from shouldering the administrative overhead of execution. Microgrants are the primary vehicle here. The Rural Health Innovation Fund acts as a distribution engine for community-led projects, pushing decision-making to the local level. These subawards are restricted to highly specific uses. They fund capacity building, technical assistance, and one-time startup costs for rural clinics. By restricting subawards to startup infrastructure rather than ongoing billable services, the state avoids accidentally breaching the separate 15% cap on direct provider payments. New Mexico's hyper-decentralized subaward network functions as a compliance tool and a healthcare distribution strategy.
There is another federal rule forcing this structure, the strict non-duplication mandate. RHT funds cannot legally supplant existing state or federal funding streams. New Mexico has a massive Medicaid population. If the state accidentally mixes this new federal grant money with existing Medicaid state share matching funds, it violates federal law. To prevent this, New Mexico relies on the policy guardrail shown in this schematic. The state prohibits RHT funds from being delivered via state plan amendments or directed payment programs. Providers will receive direct funds, but those capital injections occur outside standard fee-for-service reimbursement cycles. The state enforces this by strictly defining eligible expenses inside every subaward contract, guaranteeing there is zero overlap with billable clinical services. Structurally isolating RHT funds from Medicaid mechanisms is the only way to protect the state budget from future federal audit clawbacks. Pushing 95% of the budget out into subawards solves the state administrative cap, but it creates a massive vulnerability, tracking hundreds of decentralized microgrants for strict federal compliance. New Mexico's operational solution is to procure a third-party administrative services organization, or ASO. The ASO's central mandate is maintaining a centralized inventory. They track every funded contract from the initial award straight through to closeout. They handle the heavy lifting of federal reporting. That includes executing the federal funding accountability requirements and submitting exact federal financial reports. The ASO executes rigorous financial reconciliation methods. They identify underpayments, they recover overpayments, and generate audit readiness documentation for every subrecipient. A highly decentralized financial distribution model is only viable if it is anchored by a heavily centralized, outsourced compliance engine. Even with an ASO tracking the dollars, CMS demands proof of performance. The post-award rules require states to explicitly show how 5-year service requirements will be met and measured. Tracking long-term provider retention and measuring specialty care access improvements across isolated rural counties is an inherently difficult challenge. New Mexico answers this CMS reporting requirement with Initiative 5, the Rural Health Data Hub. This schematic details the Data Hub's technical foundation. It integrates clinical data from over 100 disparate providers by linking into the Synchrony's Health Information Exchange. The addition of closed-loop referral systems allows the state to track patient movement across the grid in real time. This technical infrastructure takes raw, decentralized clinical actions and translates them into the specific, objective performance metrics CMS demands. Data integration functions as a compliance imperative, converting abstract rural healthcare improvements into auditable federal evidence. To deploy this system, CMS requires an immediate, aggressive implementation timeline, beginning in the first quarter of fiscal year 2026. This Gantt chart maps the state's rollout. Notice the Stage 0 and Stage 1 milestones in Quarter 1 and 2. They focus on hiring staff, procuring vendors, and establishing the Innovation Center. Public-facing programs and massive funding distributions are deliberately delayed until Quarter 3. This delay is a strategic necessity. The tracking and compliance architecture must be fully operational before a single subaward dollar is released into the wild. Alongside the Data Hub, the state establishes the Rural Health Sustainability and Innovation Center to serve as the long-term technical assistance anchor for these newly funded providers. Engineering the absorption of $1 billion across a rural landscape requires extreme precision. New Mexico's implementation demonstrates how strategic administrative design can absorb massive federal capital while neutralizing severe compliance risks.